So thank you very much. So I come here today as someone who, since 2003, has had my sleeves rolled up. Today, no sleeves. My sleeves rolled up in there and really working to not just to create changes, but to actually implement them and spread them, a novel idea. And we actually started on this journey back in 2003 with IDEO, and so I'm very thankful for what we've learned from them. And since then, we've internalized this at Kaiser Permanente, and we actually are creating solutions that are being put in place with our 8.5 million members and our 45,000 nurses across 33 different hospitals. So I wanted to tell you a little bit about that journey because I think that while creating ideas is incredibly difficult, implementing them and sustaining them is rocket science. So let me go through a few things. So there's actually quite a bit I would love to go through with you. Don't get scared, I'm not going to go through all these. So I was really struggling to kind of narrow it down because over 6 years of doing this, you learn a lot. So I'm going to focus on what I'm going to call the Fab 5. I tried to get it to Fab 4 and just couldn't get there. So here's my Fab 5 of what I'd like to go through with you today. Pairing technical expertise and know-how with human-centered design skills. Avoid designing to the verbal naysayers at the expense of the silent supporters. Compliance versus compassion, it's a human story. Sharing imperfections and virtual failures. And elevating the voices of those in the trenches. So those are the things I'm going to go through with you today. So my first story is around pairing expertise with human design skills. So you heard Tim mention earlier about nurse knowledge exchange, a way that nurses are doing shift change at the bedside. That was really the first time that we brought designers in, and as a nurse myself, I have to tell you, if you would have asked me 10 years ago, would I be working with designers? And I'd say, not unless I'm redoing my kitchen. I didn't know what designers had to do with healthcare. So this was the first time that we actually brought them into a clinical setting, and I, as a nurse and other colleagues, actually started saying, how do we do this? So really we had a trio of three. We had the designers, we had clinicians, and we had patients. And we all worked together to try and find out what's not working in this environment. We focused on primarily perinatal services, and what can we do differently. So in this particular project, I won't go through all of what we came up and implemented, but it was the first time I think that I had a great appreciation of design, down to what images we should use and we shouldn't use to describe some of what happens in a healthcare setting, and to what really occurs when a woman and her new baby are about to go home. So this was an area that was ripe for some great design. We found that when a woman is discharged from the hospital, it's very chaotic, it's very hectic. And together we created some solutions to help to really empower them with information. So when you are, and a number of you have, I'm sure, been in that experience of being in the hospital and having children, there's a lot that goes on. There's birth certificates to sign, there's health insurance things that happen, there's labs that need to be done, there's education that needs to happen, hearing screenings that have to be done, and honestly, most of those things are happening with different people. Those services were not coordinated or organized together, so we created this tool that seemed very simple to help to organize what occurred. This was an image of our first prototype. So those ideas were good when we actually paired them with design thinkers and came up with a solution to show very visually what are all these activities that need to happen, what needs to be done, what's been completed. Suddenly we saw these new mothers, their anxiety levels went down, they were empowered with information, they could ask questions about what was going on, and the clinicians began to self-organize their care. So from then on, I've been definitely a champion of design thinking and working with designers. So not every experience that we've had with implementing and trying to sustain ideas has come out of wonderful examples. This is a crash and burn example. So when we were looking at shift change, we were working with 4 different hospitals at the same time. So we firmly believe that we have so many hospitals in our system, if we just work with one to create a solution, you get this not invented here phenomenon. So we extend ourselves out and we do collaborative designs, not just with the people involved and the projects themselves, but across many entities within our organization. So we had 4 hospitals involved. The short story of it is, when we were creating this way of getting nurses out to the bedside with the patients during shift change handoff, we had good success with 3 hospitals. With 1, we didn't. And there was a charge nurse in particular that was very influential, had been working at this hospital for a long time, and she said, I will not come out of this room to give shift change at the patient's bedside. I don't believe in this. I'm not comfortable with this. I've been a nurse for years, and I will not support it. So us in our naivete thought, you know what, if we just really work with her and really help her to understand this is what the patients really want, this is great, then she'll embrace it and she'll do it. That wasn't the case. So finally, defeated with our tail between our legs, we left. And we came back 6 months later and said, you know, what happened? And a very powerful moment came for me when a very shy nurse in the back of a large room of nurses raised her hand and she said, you know, I actually, and my friends, thought this was a great idea, but you didn't ask us. You put all of your energy and attention into these people that, you know what, they were never going to do it. No matter what you said, they were not going to make a change. You didn't ask us. And so that was a big aha for us is, you know, the squeaky wheel shouldn't always get the oil. When you're creating change, you need to find those silent supporters and help to support them in making the changes. So I think this was interesting given the last talk by Carl about compliance versus compassion. So I think in healthcare, we tend to think, you know, if we just can get everyone to comply, if we make this a policy, we get out and we measure it, we track if people are doing it or not, it's going to work. Well, that's one way. But we also should think about compassion. How do we really appeal to the heart? Healthcare, it's a human industry. It's humans that give the care to other human beings. And so really when you're looking at the human-centered type of approach, I think you can really get things that can be implemented and sustained much longer. So many of us have been in various different business schools. You learn things like, oh, you stick up bullet points on a PowerPoint slide, a compelling reason to make a change, and people will comply and they'll just do it. So one way that you could tell a story is to put up bullet points like this. So this example is patients transitioning from hospital to home. We did a lot of observations to understand how that happened. So I could tell the story by putting up some bullet points about what happens. The transition, once you get home is really where the transition happens. People really rely on caregivers, not always the caregivers you think, etc. What I could do is also know that, it's humans that we're trying to compel to make a change. So you can bring in these stories that show more human elements. So I'm going to show you a quick video clip of a woman, Margaret, and she is a complete character. But this is just a really quick handy cam video of her when she went home after knee surgery, trying to do the simple thing, which her physician told her is go out and take a walk.
Bit out of my knee.
Alice, hold that door open for her, would you?
And I will. Okay.
There's a little button up here.
Oh.
Watch out.
I'm watching.
Okay.
On each side of the wheel.
This way?
Mm-hmm.
Oh, okay. Just one here.
Ready, get all that. No lie. That's good.
Yeah.
Want me to put these down?
No, not yet.
Oh, God, don't talk.
I'll bet you will.
One. Here we go.
Okay. Then just go to the edge of the sidewalk. Shut up or I'm going to belt you with my walker.
So that probably says a lot more than bullet points on a slide might. When you're trying to get people to say, maybe we should really be thinking about how we're doing this and what this transition home is like. So use that, understand that at the end of the day, these are human stories, humans making the changes and humans that we're doing this for. The next point I'd like to make is around sharing imperfections and virtual failures. So virtual failures is a term that we made up, so you're probably not going to find that anywhere. But we started seeing this phenomenon that when we came up with a suite of ideas in collaboration and actually tried to put them in place, if we trotted out with this final product that our pilot sites had come up with, trotted them out into the world and didn't give any context, people were a little bit resistant. So actually, let me try this out on you guys. So here's an image of a woman, and she's one of our nurses, and she's wearing a sash. So if I were to tell you, we came up with a suite of ideas that we call KP MedRight, and one of the many components of it is this sash that we call no interruption wear. And when she wears it, it's a visual cue for people not to interrupt her. You'd probably say, yeah, okay, big deal. Well, I could tell the story in a little bit different way. So imagine I'm trying to go through why we might be able to implement these, why we should do this. And I said, well, first we started with a deep dive, and we had 70 nurses, physicians, patients, all types of folks together coming up with ideas. One of the things a nurse learned, we took them to a flight school, and we learned about the sterile cockpit. So 10,000 feet when a plane is taking off, and 10,000 feet when they're landing is a sterile cockpit, and they don't talk about anything about safely taking off or landing that plane. And a nurse said, wow, what if we had something like that visually showed we're doing something, don't interrupt us. So she, in her enactment, did this apron and wrote, leave me alone. And whenever someone would come up to her, she'd point, leave me alone. And everyone went, wow, that's kind of funny. Well, we said, well, let's try it. So we trotted out to some of our hospitals, and we tried it with one nurse, one patient, medications on a shift, and did this construction vest. And she said, the interesting idea, I actually got my medications done on time. I feel like a construction worker. I wouldn't do this. But I like the idea, maybe like a sash. So we actually had some sashes sewn, went out there. The nurse said, well, interesting, it's smaller. I still probably wouldn't do this because I feel like I want a beauty pageant. Nice idea, maybe a little sleeker, a little sexier. So we brought out red vinyl and found that we actually also included a breakaway at the end, because they were afraid, if a patient, became unsteady, they might be pulled down. So that was an interesting thing that we learned. We also learned that she said, great idea, I can actually clean it. And so from an infection control standpoint, great thing. So then we got to the point where we brought out this reflective sash. It's reflective on both sides. You can actually see it at night, and it's part of a suite of solutions. You're probably now more open, now that you've seen our stumbles along the way, you're probably more open to the final idea. So I recommend and encourage you to share your virtual failures with people. So my final point is around elevating the voices of people in the trenches. We've got to get comfortable enough with our ideas to let other people take credit for them. In particular, the owners of the ideas, when we're making changes in a healthcare system, let's say in the solution I was just telling you about with medication administration, those nurses own those ideas, and we promote that they actually are the ones that are doing this. They are the ones that apply for awards, they're the ones that share it. So I wanted to show you with a quick video clip from a few nurses as they talk about their experience in creating what we call KP MedRight.
The nurses up there walk around with such great pride. Just say, wow, we created this. They saw how it looked from the very beginning when we put on a construction vest up to the very end where now we're wearing the sash and we're actually saying we have 0 med errors. And not only that, we're going out there to other Bay Area hospitals and we're sharing that with them. And that to me is the greatest sense of pride that every single nurse up there is walking around.
They want to participate and create other ways to improve the environment that they work in. They can make a difference.
So you're kidding yourself if you don't think that those nurses want to make sure that those ideas stick around and that they're going to be there, 6 months, 2 years, 3 years out into the future. So I know that you all are change agents in your own organization, so that I hope that some of these tips, there's a number of them I'd love to go through with you, but I hope that you find something here, whether you're the ones that are actually implementing the changes or you're the champions of changes. I hope that you've been able to find something that you can take back to really help to do it, because I do believe that that's where the rubber meets the road, and if we can't find changes that we can actually implement and keep around, then what's it all for? So thank you very much and good luck.